Disability Services, and I chair the Faith and Culture Network. The Faith and Culture Network has been around for the better part of a couple of decades, and we've been working within the developmental services in Ontario to try to help service organizations and the ministry to be more deliberate about how we engage people as it relates to matters of spirituality and that sort of thing. Um, and so this past fall, we decided that we would want to take some of the great learning that we have access to in our individual organizations and make it available to more people in the form of these webinars. And so we had a great one on Hanukkah back in early December, and we've had some from the Catholic Charities in September, October. And so we're quite pleased about that. And you can watch your email because we're continuing to have some of these. We have another couple of scheduled for February and March, and we'll put that out pretty soon. But today I'm pleased to introduce Liz Froese. Liz is from Bethesda. Liz will do a better introduction of her and Bethesda, and then she's going to introduce John, and we'll get right into it. John's taking 40-ish minutes to walk through his presentation. And, if there's a burning question that you have or comment, use the hand raise feature, and John can navigate that. But we want to make sure that we also have time at the end so if it's a point of clarity that you need, ask it in the moment. If it's a question that's a bit more general that would benefit from us spending a minute on, make a note of it, and we'll leave some time. We'll take 10 to 15 minutes at the end after John walks us through his work to be able to learn together in that fashion as well. So I'm done. Liz, I'll pass it to you.
Thank you very much. It's my pleasure to introduce Dr. John Keesler to you. I'm Liz Froese. I'm the soon-to-be retiring Director of Adult Clinical Services at Bethesda, and I work with Leah Jeffrey. She was supposed to be co-presenting today, but unfortunately she's not able to present. So John has graciously jumped in and said he can do it. So thanks, John. Bethesda's been on a journey for several years of how to become a trauma-informed organization. And in that journey, we worked with University at Buffalo to implement their organizational change model. And through discussions with University at Buffalo, we said, do you know anybody that knows developmental services sector and trauma-informed care that you could hook us up with? And they hooked us up with Dr. John Keesler. And we've been working with John over the last several years on a research project that's been really exciting. And when we were developing Lunch and Learns, I thought John and Leah would be really good to talk about faith and culture through a trauma-informed lens. And that's what John's going to do today. So John, thank you very much for coming and sharing your expertise with us.
Thank you, Liz. Thanks, Dwayne. I'm hoping I can effectively share my screen here, so just bear with me for a second.
It looks like we're about to see it. There we go. We can see your full screen, John. The slides on the left-hand side, and then the main slide in the middle.
Are you, I hope I am sharing just the main slide at this point.
No, we see it everything.
Okay.
So we can see your full PowerPoint file or Keynote, whatever it is.
Well, let's try it this way.
Sure.
Hang on one second, sorry. Okay, so something's going on with my screen. I'm going to stop sharing just here quickly. Okay, now you should just see the main slide, correct?
No, we see the index as well on the left. It's not distracting, so.
Okay. Okay, so we're just going to go with it
Sure.
for the sake of time. So my background is in trauma-informed care. I've been focusing on this since around 2010. I actually published the first article ever to discuss trauma-informed care in the disability service sector. But I am able to marry the topics of trauma-informed care and faith in large part from lived experience. So again, my name is John Keesler. I'm an associate professor at Indiana University on the Bloomington campus in the School of Social Work. I'm originally from Buffalo, New York. Spent quite a bit of time in Ontario, particularly Niagara Falls and Toronto. So I'm no stranger. Um, but I want to acknowledge at least some of my bias in this presentation, in that my background is as from the Catholic faith and the Christian lens. So that's going to be my foundation from which I present. That is not to exclude other faiths or religions. It just is my own frame of reference. So, as a social worker, it's important to acknowledge that I approach things from a systems lens as well as from the person and environment. I do not believe that you can focus on the person without considering their environment, the systems within which they interact, whether that's the family system, the community system, the organization, etc. And I largely focus on practice-informed research. For me, my research in trauma-informed care is meaningless unless it's grounded in practice, in my former practice as well as the practice of others. So hopefully that's coming through in this presentation. It's interesting to me because early on, I had an interest in trauma, particularly from World War II and the Holocaust. And so hopefully I draw in some insight and wisdom from folks that have survived the Holocaust and make it relevant to today's presentation. Elie Wiesel survived the concentration camps and talked about, human suffering anywhere concerns men and women everywhere. I think that each one of us in our own life journeys struggles with various different things, whether it's traumatic or not. It's part of the human experience, and oftentimes we suffer alone. But the fact is that human suffering really concerns all of us. And especially when we talk about the intersection of suffering and disability, oftentimes as support staff, as organizations, and as providers, we need to be mindful of that we oftentimes focus on keeping individuals happy, engaging in positive behaviors, but the fact of the matter is suffering is part of the human experience. And just a little bit more wisdom to guide us through this. Sorry. This is from Viktor Frankl's Man's Search for Meaning. We may also find meaning in life even when confronted with hopeless situations, when facing a fate that cannot be changed. For what then matters is to bear witness to the uniquely human potential at its best, which is to transform a personal tragedy into triumph. And so much of the work that we do in disability services is about bearing witness. And that's something we oftentimes don't talk about. We don't recognize the challenges of being present with somebody, of supporting them through their life journey, and honoring that, and not recognizing the privilege that we have to bear witness to other people's lived experiences, but also to bear witness to our own experiences. And the more one forgets himself by giving himself to a cause to serve or another person to love, the more human he is and the more he actualizes himself. So we actually become something more than when we engage in this work. And all of this aligns well with trauma-informed care. It may not seem like I'm getting to the point, but believe me, I'm getting to the point. I have early roots in church work. Faith, religion has always been important to me. It was a source of strength even as a teenager, and was important to my grandmother, who was also a huge source of support for me. I'm not going to get into too much of my own personal struggle, but life has not always been easy. But I have found that faith and prayer has been a source of support. As a teenager, I actually volunteered in a religious ed program. I had no idea what I was doing, but I agreed that as part of my service as preparation for confirmation, that I would support a child who had had multiple disabilities. And it was a Saturday program, and it was about inclusion. And I was challenged with supporting this young man, Michael was his name, and helping him to learn more about the faith. And how was I to do that? I had no training, no support. I was just said, here's a responsibility, go and do it. That is not uncommon for most of us. We get into this work because we have a passion. We're not necessarily always receiving the support or guidance that we need, and we oftentimes do the best we can with what we have. Simultaneously, I had also worked as a maintenance person in the church pictured here, which is Our Lady of Victory Basilica, which is in Lackawanna, just over the Erie border. And I did maintenance there. And it was interesting to me because my maintenance job actually turned into more of a tour guide. People wanted to know more about the church, about the history of it. And so I delved more into the history, and so much of the work of the church was around social services. Dating back to the 1800s, the Sisters of St. Joseph had supported young boys, and Father Nelson Baker, the pastor in the early teens and 20s, expanded the services to include support for unwed mothers, infants, adolescent boys, and in teaching them all sorts of trades. And the fact is the institutions here are still in operation today. And so I didn't know then what I know now about how I would be connected to all of that and the mission, not only of the church and the services, but also their support of people with intellectual and developmental disabilities. My journey has been trauma influenced from my own experience of trauma, from those of family members to those that I've seen and supported. I was involved in music ministry for 22 years, and did that right through getting my PhD. And my life ebbed and flowed from an associate's degree in music to taking time off to getting a bachelor's degree in psychology, social work, and then finally my PhD in social welfare. But while I was working in the field, I was exposed to Judith Herman's book, Trauma and Recovery. And if you're not familiar with that book, it's a heavy read. I encourage you to read at least the first few chapters of it, because it talks about the ebb and flow of our interest in trauma. And it provides a solid foundation for understanding what trauma is and what that recovery process is like. Simultaneously, in the academic world and in the research around this time, people were beginning to question, is post-traumatic stress disorder something that's appropriate for people with IDD? And the answer is yes. And so much has been learned since then. Bessel van der Kolk is a psychiatrist who focuses on trauma. He's a world expert. And I like this quote from him that life sucks a good amount of time. We oftentimes don't feel comfortable talking like that in public settings, but I think it's important to acknowledge that life is difficult. We all have we all have jobs and situations that are really unpleasant, but the moment that a situation is over, it's usually over. But the problem with trauma is that when it's over, your body continues to relive it. And so if you have had experience with trauma directly, then you know what this is getting at. So what exactly is trauma? For a long, long time, it was thought that it was outside the range of usual human experience. That was really until 1998 when Dr. Felady and Anda did their study in California among 16,000 people and realized that particularly adversity in childhood was really common. So common that they were astounded by that. Excuse me. And that really catapulted services and the health sector into recognizing the importance of addressing trauma and that we have to do something not only to address it once it's occurred, but we also have to do something to prevent it. So from SAMHSA, the Substance Abuse Mental Health Services Administration at the federal level in the United States, they provided us a common definition of trauma, the 3 E's. So trauma results from an event, multiple events, or circumstances like poverty or neglect that an individual experiences as physically or emotionally harmful or threatening, which may have lasting adverse effects on the individual's functioning and well-being. Keep in mind that well-being does include spirituality, something that we oftentimes don't focus on in the disability sector. It may be experienced by an individual, a generation, or an entire community or culture. So again, the 3 E's, the event, the experience, and the effects. Oftentimes we talk about trauma as an event, but actually that is not correct. Trauma is actually the aftermath of that event from our experiences and the lasting effects. So just keep that in mind, that it's not outside the range of usual human experience, But simultaneously, trauma isn't just stress, it's something more than that. So, as I had mentioned in 1998, Felity and Anda had done research around adverse childhood experiences. Extensive work has been done around that over the past 20 plus years, but also our understanding has grown tremendously. And that it's not just enough to consider what's happening in childhood in the household. So, adverse childhood experiences, for those that don't know, are 10 types of adversity that happen before the person reaches age 18, are divided across household dysfunction and abuse and neglect. So, things like parental divorce or separation, substance use in the household, incarceration, domestic violence, and substance use, if I didn't already say that. And in child, the abuse and neglect, so physical and psychological abuse, sexual abuse, emotional neglect, not feeling loved, and physical neglect, not having your basic needs met. Those things are significantly important to well-being in adulthood. But there are many factors that can influence their impact, such as neurobiology, the environment, resilience, etc. But anyway, adverse childhood experiences are only one part of what we need to consider in understanding adversity. We need to look at the community. Are our communities safe? Are they resource rich? Do they lack resources? Is there community violence? Also thinking about climate and climate change. And then culture. What does the culture look like? Are we talking about the culture that involves slavery? Are we talking about culture that involves anti-Semitism? Are we talking about culture that focuses on ableism or heterosexism, etc.? All of these things can be sources of adversity that impact a person's experience of trauma. So trauma has lasting symptoms. We know that, and they can range. Historically, from a diagnostic perspective, we've focused on four domains around hypervigilance, so being easily startled, sensitive to environmental changes or cues, intrusive thoughts, memories, or flashbacks, so nightmares, not being present in the moment, avoidance of stimuli that remind you of the trauma. So maybe being disengaged, shutting down, avoiding certain spaces, certain stimuli, being combative and refusing to participate, running. These things can be associated or the manifestation of avoidance. And negative changes in thoughts or mood, being depressed, seeing the self as bad, seeing the world as bad, being anxious, etc. But there's others as well. Again, as we've learned about trauma, we have recognized that these four categories are not enough. So a person can have an extreme, unusual, or blunted, or sort of less than effect than you might experience. So situation, response, and congruence. You might ask somebody a question and they go off the handle and they just start screaming at you, something where you really didn't expect that sort of response. Irritability, aggression, destruction, being stuck in a state of dysfunction or ruminating, talking about it over and over again. Physical distress, certainly physical symptoms are a huge indicator and oftentimes missed as being associated with trauma, but headaches, upset stomach, and pain. Certainly relational and work problems, changes in sleep and appetite, a sense of shame and brokenness, hopelessness, defensiveness, and even a loss of faith or belief in God. So when we talk about trauma more specifically with people with intellectual and developmental disabilities, all of what I've said is true. It definitely applies to people with disabilities, but we need to think even broader about events and circumstances that might be potentially traumatic for the person. We need to recognize that the caregiving context exposes the person inadvertently to potential for harm. Whether that's a paid caregiver or a family member, the fact is we do the best we can. We don't oftentimes intend to cause harm, but sometimes our actions do cause harm. Sometimes we get stressed out, burned out, and that has implications for the individual. but also think about insidious trauma or the daily experiences that go under the radar, being excluded, having a disability, and recognizing that you're different and not fitting in. So for people with disabilities, we need to consider this idea of intersectionality of not only their disability, but their cognitive capacity or differences, their developmental stage, what supports and resources they have available, their demographics. Are they a person of color? Are they indigenous? Do they identify as lesbian, gay, bisexual, transgender? What is their identity? Do they even have an identity? A lot of times people are confused about who they are, especially people with disabilities, especially those that might be in the mild or borderline range of intellectual functioning. They're not quite sure where they fit in. Trauma symptoms are definitely like those without disabilities, but potentially different. We need to think about apparent loss of skills or regression. So people that might have no issues with toileting might begin to have issues with toileting or sleeping or eating. They might act out in sexualized behaviors and certainly increase dysregulation as well as behavioral incidents. But all of that being said, let's take a step back, think about the people we've supported in our organizations and the work that we do in our faith communities. The fact is people with IDD are resilient. They have been through so much in many cases. I'm not sure I would have been able to survive what some of the people I've supported have gone through. And so we cannot fail to acknowledge that people with disabilities are indeed resilient. When we talk about trauma and adversity, something I oftentimes talk about is this idea of a common bond, whether we like to recognize it or not. People with intellectual and developmental disabilities have higher rates of exposure to potentially traumatic events, as well as developing trauma responses. In the general population, people with post-traumatic stress disorder is about 7%. Amongst veterans with combat experience, it's around 20%. And for people with developmental disabilities, it's between 10 and 40% that might have post-traumatic stress disorder. Many people with disabilities, intellectual and developmental disabilities, are never diagnosed. The trauma goes under the radar. We oftentimes attribute their problems to the disability or to some other mental health issue. And many providers are not well trained in trauma assessment, or trauma-specific treatment. Additionally, what we know is people that get into helping professions have higher rates of trauma and adversity in their lives. I've done some research around direct support professionals, and almost a third of direct support professionals had had 4 or more types of adverse childhood experiences. That's in their own personal life. So 34% experienced emotional abuse. About a third came from households with mental illness, 30% substance abuse in their family, and lack of support. Again, you can see here that people that are supporting people with trauma histories have trauma histories themselves. And we need to be mindful of that intersection because that can get, oftentimes people get into the helping professions to help people, to protect them from experiencing the same things they've experienced, but also it can be very dangerous in that staff persons don't address their own trauma, either before working with other people or while they're working with other people. And it can create a little bit of a messy dynamic. The other concern is secondary traumatic stress, and that's emotional duress by persons having close contact with people that have experienced trauma. And so more than 80% of DSPs in a recent study were acknowledged supporting clients with trauma histories. And about 1 in 5 DSPs had increased levels of secondary traumatic stress. So things like intrusive thoughts about clients, a foreshortened sense of the future, and difficulty sleeping and concentrating. So we need to be mindful of the well-being of our support staff and family members as well. Here we get closer to this intersection of trauma and spirituality and healing, in that we are interdependent. Our faith communities are a place where we interact with others, where we get to know each other. We have a sense of community, hopefully. But keep in mind that there's a disconnect here with disability services, at least in the States, which I'm far more familiar with than in Canada or Ontario specifically, is that we oftentimes focus on highlighting independence. We want individuals to be independent. that is in direct opposition or juxtaposed with this idea that we're actually very interdependent. The fact is that we're here today in this Zoom meeting. We are interdependent. We have this organization provides a sense of community, but also we're interacting and learning from each other, hopefully. So intact relationships are generally very important for us surviving or getting through traumatic events. As long as our foundation of safety is maintained when somebody is there, we are generally okay with trauma. That doesn't mean it's not going to have an impact. It just means that we are better off. Relationships, healthy relationships, are hugely important. Yet people with disabilities are oftentimes and disproportionately so excluded and isolated from supports that they need. So trauma, the context for most trauma is in fact human relationships, caregiving, natural paid supports, people we know. Even more so than natural disasters, trauma between two people is more profound, more significant, broadly speaking. And what happens in the immediacy of a traumatic event is we have a loss of safety, loss of control or sense of agency. We didn't have a choice in the matter. Now think about this from the disability perspective. Many individuals already lack a sense of safety. They already lack a sense of agency due to paternalism, ableism, and they don't oftentimes have choices in matters. So let's amplify that with trauma. So it becomes far more complex, compounded. But what will it take to heal? And that's restoring trust in others, physical and psychological safety, predictability, follow through, allowing individuals to have a voice, ability for self-expression, not just words, but who are they? And that can take on different forms and different modalities of communication, being empowered, having options, engaging with others. It's about connecting. But remember, when we develop relationships, we take a chance, we risk that connection. We have to be vulnerable to some degree on our part, as well as the person we're trying to interact with. So spirituality, religion, and faith, these are all a little bit different, but oftentimes interrelated. So spirituality, it's a process of life and development. It's a focus on a search for a sense of meaning, purpose, and well-being. Simultaneously, trauma is also about a search for meaning. We're oftentimes trying to make sense of why did this happen to me? What could I have done differently? What does it all mean? Spirituality is also in relationship with oneself, others, creation, a higher power. And it's about engaging in a sense of transcendence and hope. While transcendence can be a very difficult concept to grasp, I think most of us can fully understand the concept of having hope. Religion is an organized pattern of values, beliefs, and symbols, behaviors, and experiences. It involves spirituality. It's about a community of followers, sharing of traditions over time, community and individual support functions that are related to spirituality. And religion oftentimes involves a sense of rituals, engaging in senses, and creating structure, lends to predictability. Think about this. The people you work with and support, people with disabilities, often need structure. They need a sense of predictability. It helps them to make sense of the world. For somebody with anxiety, I love predictability. I love structure. I need that to survive. I need that to thrive. And for me, religion and worship also offered that sense of predictability. I knew what I was going to get into every time I went to Sunday services. And so think about that and the importance of that from a disability perspective. And faith is having a belief or trust in and loyalty to God or a higher being, belief in traditional teachings of a religion. Remember, I talked about trust as being destroyed by traumatic events, and faith is about having trust in. So you could see the potential difficulty here when we talk about the intersection of trauma and faith or religion. When it comes to spirituality, when it comes to churches or worship or getting into synagogues, etc., mosques, people with the IDD are much less likely to attend services. But that's not because religion and faith aren't valued. It's not because they're not important. The fact is that there's barriers. physical limitations to actually accessing the space, communication differences, lack of transportation, lack of support staff or staff who are reluctant or resistant to engage in a space that is religious or affiliated with a particular faith, societal attitudes that can turn people away and make them feel unwelcomed or unwanted, and faith leaders who lack training, particularly around supporting, and not only supporting, but embracing and welcoming people with disabilities into their congregations or faith communities. Like I said, trauma is about finding meaning. Spirituality often provides a system for making meaning. Why did this happen to me? Why would God allow this? And oftentimes needing to reconcile difficult events with beliefs. Spirituality can create a sense of empowerment and in turn increase mental health. It can also help when positive relationships buffer trauma and are a source of comfort, support through prayer or the faith community. But spiritual struggles may focus on relationship with God or interpersonal relationships or interpersonal matters, but that could lead to one doubting their faith, lacking meaning in life, faith leaders who have perpetrated acts of violence, congregations who have led people to feel unwelcomed, and certainly doubts can lead to decrease in religiosity and to greater distress. How can we facilitate deepening a person's relationship with God when the fabric of that person's relationality has been rent or destroyed by the effects of trauma? The fact is trauma-informed care is one part of that solution. Trauma-informed care is a way of responding. It's a way of being. It should be our sort of a universal precaution when we interact with folks. It's based on 4 R's. So realize the pervasive impact of adversity and trauma, recognizing the signs of trauma that people experience, recognize the manifestation or how trauma appears in behavior, responding by applying the practices of trauma-informed care, and resisting causing further harm or re-traumatization. This is completely different from trauma-specific treatment. Everybody can use and implement trauma-informed care, whether that's at an individual level or systems level, but trauma-specific treatment often requires advanced training and is really specific to addressing and treating that trauma. Trauma-informed care is based off of 5 principles. Some of these should be very familiar based on what I've already talked about, particularly things like safety and trust, choice, empowerment, and collaboration. Remember, trauma either prevents an individual from experiencing these things or destroys these things for that person. Think about sexual assault, psychological abuse, etc. All of these things don't involve safety, break the trust. The person has no choice. They're disempowered, and they're certainly not willing participants. It's trauma-informed care is where the past meets the present, recognizing that past trauma can be very much in the present. It's about cultural sensitivity, recognizing, particularly in this context, the influence of institutionalization, the influence of paternalism, the need to protect people, not allowing for dignity of risk, ableism, and diminishing the abilities that people with different abilities actually have. Trauma-informed care is action-oriented. It's about doing something. It's not just about knowledge. It's about applying that knowledge to how we care, what we say, and what we do. It's restorative. It's not about what's wrong with you. It's about asking what has happened. It's about creating that open space for people to feel welcome, to feel comfortable, and to engage in dialogue with us. So in action, what can we do around trauma-informed care? First of all, in faith communities, what is the overall message? What is the messaging in the place of worship? What's the messaging in religious education programs? What's being said from the pulpit or the ambo? What are the religious leaders saying in their homilies or sermons or preaching? And what about in Bible study? What are the messages that we're giving around people with disabilities? What are the messages we're giving around trauma? Are we stigmatizing and shaming people, or are we recognizing and embracing them as broken or wounded, that need healing and support, and that are worthy of that. We have to resist temptation to quickly theologize suffering as redemptive. No pain, no gain. That is not entirely helpful for many people, especially when they're trying to make meaning of their experiences. And we cannot forget the perpetration by various faith communities and faith leaders. We need to be sensitive to that. Many folks have been impacted by that, maybe not directly, but either through media or even family members. Safety. So if we are a support person, whether paid or natural support or family member, and we're supporting an individual with disability in accessing a congregation, we need to think about these principles of safety, choice, collaboration, etc. For the person with the disability, is it safe for them to ask questions, to explore their beliefs, or are they just told that they have to follow what's being preached? Is it safe for them to be themselves? Do worship services take into account that people have different sensory needs or sensitivities? Are faith communities and leaders willing to perhaps forego the use of incense or dim lighting or decrease the volume on their sound systems, decrease lighting, or have special services that are more welcoming and comfortable for folks with sensory differences? Are members of the congregation, as well as the leadership, aware of people with disabilities, understanding the differences, and willing to respond and support them in helpful ways? Do individuals have the ability to choose how they worship and worship as best as they can? Do they have opportunities to join different ministries? Are they genuinely welcomed as somebody with different abilities, as somebody that can enrich the congregation and share their lived experiences? Are they engaged as equal members? Is there follow through? Is there privacy? All of these things, are they encouraged to actively join others in worship and in ministry? And are they places where people will learn and explore their experiences with them in the context of their faith? Carter is a researcher, and I'm mindful of time. And I know I've gone through, there's a lot of content here. 40 minutes is difficult to cover it all, but a sense of belonging. And there's a belonging wheel that has these values of being loved, being present, invited, welcomed, known, accepted, etc. It's not just about being included. It's about having a sense of belonging. It's about being reached as a person not only with a disability, but also somebody that's likely experienced trauma. And when we consider faith communities and what people with IDD value, the fact is they value a role in their congregation. They want to do something. They want to have a sense of purpose. They value the relationships and friendships that are formed in the congregations and with other ministries. And they value the sense of tradition, routines, and familiarity. So again, that structure of ritual. But simultaneously, we need to be mindful for the faith leaders. Faith leaders are oftentimes up against a wall and they experience a lot of stuff. They have a lot of joyful things, but they have a lot of also sad things as well. As a director of music, I played for many, many funerals, and I didn't cry any less at any of them the longer I did it. The fact is ministry involves a sense of grief and loss and burnout, as well as secondary trauma. So we have to be kind to our faith leaders as well. And faith leaders need to be kind to themselves. It's essential that they examine their own attitudes, values, behaviors, boundaries, and limitations. Understanding that how they perceive things may not be the same way as others or what's being communicated with them. And their beliefs and others may come into conflict with each other, which creates challenges for pastoral care. And being self-aware. Oftentimes when we work with people, their pain also becomes our pain. So we need to have good boundaries. That can be hard to do, but supervision, peer support is really important. And having a sense of practices for self-care, not just something you do like get a massage once every 2 weeks like I do, but actually thinking about your self-care on a daily basis in the work that you do, and encouraging organizations to support self-care as well as staff care. It needs to be an ongoing practice and part of everyday life. And if there's any faith leaders in the Zoom audience, There are some resources out there specifically for clergy around trauma and PTSD, so I share that there on the screen. With that being said, I am mindful of time. I've stayed, I hope, within the limits. I'm going to stop sharing. And if Dwayne or Liz want to help facilitate, that's great. But if people have any questions that I might be able to answer, I'm happy to do that as well.
Liz, I don't mind helping to facilitate if you're okay with that. Yeah. Um, John, thank you so much. There's a couple things that were familiar to me as you presented, and like, okay, I've learned that before, but there's a bunch of new things as well, and I so appreciate it. Um, uh, and thank you for being willing to perhaps take some questions now. So perhaps there was something that resonated with you all that you heard that you want to just be able to speak back to John and let others hear because it might be helpful for the emphasis. Perhaps there's a question that you have for a bit more information on something that he shared. Just you can wave at me or use the digital hand. Jody, go ahead.
Thank you, Dwayne. Thank you, John. I have been in developmental services for some time, and I've worked in a variety of areas. So I've worked in the institutional care and I worked in group home care. So I've seen what you've spoken of. I've seen the trauma that stems from the institutional care and stems from home life as well. Have you seen in your work a pattern of the comorbidity of for people who are more independent for substance use and abuse?
You mean people with developmental disabilities also struggling with substance use?
Mm-hmm.
There is actually some increased attention to the comorbidity of disability and substance use. I have not encountered that personally in a lot of my work. And the reason why is probably because organizations either A, didn't talk about it, didn't serve people with co-occurring disorders in that nature, um, or we were just ignorant to it, quite frankly. Um, so I think it is important to recognize that substance use can be a way of coping with trauma and trauma symptoms. But substance use also can increase one's exposure to potentially traumatic events and dynamics. And so, yes, I am not proficient in that area. I can understand it. And I say that we need to do more work in that area. Yes. And that also complicates how we support people too. Um, so that's an excellent question and observation. Yes, it makes good sense to me as an intersection that we need to work on.
Thank you so much.
Yes, you're welcome.
Thanks, Jody. Thanks, John. Others? Go ahead, Lydia.
I was just wondering, are there any resources that you are aware of for support staff if they become aware that someone supported has some kind of trauma? They maybe tell a story from their childhood, something that, or maybe they exhibit symptoms of PTSD or other traumatic symptoms. Are there resources? Again, I know you said you're not that familiar with Ontario, but what would you recommend for that type of situation?
So, a couple of things is I think that we should be training all staff in recognizing trauma and trauma symptoms, as well as embracing trauma-informed care. Um, and Bethesda can be a resource for you. But with that being said, I think first is one, listen. Listen to the person with lived experience. It's not your job to discern whether or not what they're telling you is the truth. It's your job to advocate that they have access to the support that they need. I would say go to your program manager, share your concerns, share your observations. Or if your organization offers mental health services and has an internal system for referrals. The fact is that we need to be sensitive to that. For far too long, we have denied people with disabilities that they can be and are honest reporters. They do know what they've lived through, and they can self-advocate, and we need to honor that. But also that burden should not be placed on direct support staff to worry about treating that because you're not qualified. But at a minimum, you can provide trauma-informed care if you're trained, etc. Resources, I'm not sure of anything beyond that. I think one, training and awareness is critical, and referring within your organization to higher ups or leadership would be the way to go. Yeah, that's the best I can respond in this context.
Thanks,
Thank you.
John. Thanks, Lydia. Stefan, you had your hand up and now you've removed it.
Thanks, Dwayne. I don't know if my question, it was more a curiosity, John. There was work a few years ago to have developmental trauma disorder introduced into the DSM or the text revision, one or the other. And I'm wondering if you're familiar with any of that work for the DSM-6, if there's any anticipated outcome there. One of the challenges was the lack of empirical evidence. I don't know if that's due to the way clinical practice for folks with disability is practiced, or just the interest from the academic community. But wondering if you had any insights there, or were aware of any of the work going on or continuing to happen.
Yeah, I can't speak to that because I honestly don't know. However, what I do know is that what's happening in the academic and research sector does definitely inform and influence to some degree what goes on with the DSM. Sometimes there's controversy there between those that are actually writing it and what science says. I've heard numerous stories where things have been negotiated. But I can tell you that in the research base, there is far more now than there has ever been before around trauma and people with disabilities. We have grown immensely in the past decade. When I first started talking about trauma-informed care, I was the only one pretty much standing on a limb trying to make a career for myself, being told I didn't know what I was talking about, being rejected in American-based journals, but being accepted in international. But now there is a wealth of knowledge out there. So I suspect that as the DSM is revised, that we may move more in that direction of recognizing the developmental impact.
Thank you.
Thanks, Stefan. Thanks, John. Don? And after Don, maybe one more question.
John, great information. I was wondering, I guess it's more of a request, the one slide where you had the sort of wheel of belonging and the two slides prior to that, to me, resonated as a bit of a checklist to keep one grounded, because certainly in my work with people with developmental disabilities and connecting to places of faith, we sometimes get trapped into thinking that's a good place for them to be and they'll be accepted. But I've also sat in some meetings with parents where certain parishes have suggested they not come back because they find that their other parishioners find their son or daughter to be a distraction. And so I'm wondering whether we would be able to get maybe at least those three slides as possible resources, and maybe through Liz can come back to our network and could be available to people as just a bit of a grounding and a checklist for us.
Yes, of course. I mean, those questions I put together on my own. They're not a validated measure, but certainly can be used. I'm happy to share anything. Carter, I can't remember his first name, who came up with the belonging wheel, certainly does a lot of research in the area of disability and spirituality, not so much in trauma. But yes, I can share that as well.
And I'll add a chair note. I think you're referring to Dr. Eric Carter,
Yes.
John? Yeah, he was at Vanderbilt, and I think he's moved. And I name him. We know him. We've done some of the stuff within Caris. But Don, Eric was one of our speakers, I believe, when we hosted the Oasis conference a few years ago. So, yeah. One more question for John. A lot of pressure on someone to make the last question.
Well, I can make a
Pause for Liz.
comment.
Go ahead, Liz. You got it.
We've really learned a lot with our work through trauma-informed care with Dr. Keesler. So if any organization would like to learn more about how to become a trauma-informed care organization, just reach out to Leah Jeffrey. So it's ljeffrey@bethesdaservices.com. She leads our project here, and she'd be more than willing to help either present or just walk alongside you as an organization as you become more trauma informed. So again, it's ljeffrey@bethesdaservices.com.
That's awesome.
Thanks.
Thanks, Liz. And Sal, we can add that piece of information into the email when we send out the link to people. Thank you, everybody. I want to publicize our next two webinars. I have the details in front of me. But Dr. John, thank you again so much for being with us. Are you south of the border right now? Or are you in Canada? Are you?
I'm south of the border. I live in
Okay.
Indiana.
Okay.
But if folks have questions, I mean, feel free to reach out. I hope that I don't identify necessarily as a traditional academic. I hope I'm accessible to folks. Happy to provide resources and help however I can.
That's awesome. Thank you. Thanks for that. I appreciate that. Our next, so mark your calendars. Funnily enough, I moved the screen. Here we go. The February 10th, we're quite excited because our friends from Tamir in Ottawa and Rena in Toronto, two Jewish organizations, are going to talk with us about Passover and inclusion and what it looks like for us to be able to support service users in our organizations who are Jewish and want to participate, or if they're not and they want to participate in Passover. So we'll learn a little bit about that. So that's very exciting. And then so that's February 10, right? And then March 24, Bethesda is hosting another webinar, bereavement supports for individuals and direct support professionals. And both of those topics are very pertinent and relevant for us as we support people in different faiths and as we support people who are aging and dealing with the reality of that, of people passing away. And then we have a couple of other ones that are in the works that I won't name yet. But one thing that we do want to host in this series of webinars is an opportunity for us to hear from community participants and the kinds of needs that you're seeing as it relates to matters of faith and spirituality around the people that use our services. And so we'll have more about that in a future announcement as it relates to a webinar. So thank you all so very much for participating. I trust it was helpful for you as it was for me. And have a great rest of your day. Bye-bye.